Good morning, everyone, and thanks for joining us. This morning, we are honored to have Dr. Mike Maxwell join us from the North Olympic Healthcare Network, also known as NOHN locally. He is going to be presenting to us about their larger program that they have within our county and how it has morphed over the years from a private practice into something called a federally qualified healthcare center, I believe, if I've got that right. So a little bit of housekeeping, if you'll keep yourself on mute, and if you'd like to ask any questions, you can either put it in the chat or raise your hand. We like this to be somewhat interactive. This will be posted on our website by this afternoon. And so you can share the link with other people with that link. So with that, Dr. Maxwell, please take it away. And thanks so much for joining us.
Hi, Colleen. Thank you. Welcome, everybody. As Colleen said, I'm Mike Maxwell. Those who don't know me, I'm a family physician who has been practicing in Port Angeles for about 30 years. That was up until I did family medicine, high risk OB, up until 2015 when I took over as CEO of North Olympic Healthcare Network. Just this past July, I hung up my stethoscope to do the administrative work full time as we've grown. Colleen and Lori came by to visit a little while ago and thought, maybe you might want to, present on the Coffee with Colleen. I thought, are people interested? We kind of fly under the radar, but she thought there might be enough of interest that I'm presenting to you this morning. So hopefully it is something of interest, and there's some kind of cool stuff that's going on. We just kind of do the work and fly on the radar, and we think it's pretty interesting, and hopefully you will as well. So I'm going to share my screen, and hopefully I'm going to share the right part of my screen. How's that look? Never quite tell. Are people seeing the presenter view or the slideshow?
We see the slide, next slide, and no notes.
Gotcha. Now I want to show you this one. That's better, right?
Yes.
That looks more great. Okay, so I think the best place to start is just with our mission. And it is to provide patient-centered, quality-driven, whole-person healthcare services that are accessible to everyone in the community. In my presentation today, I'll kind of give some background about why each of those words or phrases has a lot of meaning for us. We are really committed to each one of those words, and this presentation today will give you a little sense about how we got there. Probably might be helpful to start out with a little bit of background and history. And by the way, as Colleen mentioned, I'll be able to answer some questions at the end, but if there's anything comes up in the course of the presentation that people have a particular question about, please get my attention or Colleen's attention. I'm happy to answer any questions along the way. But I like to say that we're an old organization that became new again. We started out actually as Family Medicine Port Angeles about 35 years ago. We were on a little house on 16th and C Streets. It's still up there. It was a little residence that got converted into a clinic. Started out with 2 physicians, I think a total of 9 employees back in '79. It was a private practice. 2 physicians finished residency in Spokane and came out and started up this family practice. By 1991, it had grown to 5 physicians. I was the 5th partner to join the partnership at that time, and we outgrew the little house and ended up building the spot on 8th and Cherry that's still there now. I think the hospital uses that for a special clinic now, but that was built to accommodate my arrival with that growth. By 2009, we actually had increased to 8 physicians, 8 partners, and 3 APCs. That's advanced practice clinicians, that encompasses both nurse practitioners and physician's assistants. And we outgrew that space, and that led us to move ourselves downtown. So this is a photo from when we deconstructed the City Light Operations Building back in 2009. We were this is actually 2009. I think we were the first new construction down in the west end of downtown in some years, and built the Downtown Health Center. But by 2014, we had reached the capacity not for the space, but for the model. Over that 35 years, there had been a shift in what physicians were looking for when they finished residency. They weren't looking to invest in a practice, buy into a practice, run a business. They were primarily interested in coming someplace to work and focus on the patient care. And so we realized that the model that served us so well and successfully for so long just was not going to be a successful model going forth to bring new people to the community. And for those of you around in 2014, might recall that if you did not have a physician in 2014, you were not going to get one. Regardless of your insurance, there just were not enough primary care providers around. We found that our recruitment was challenged not only by our private practice model, but being a rural area that's hard to attract physicians, primary care physicians, particularly into. There were primary care shortages nationwide, and around 2010, the Affordable Care Act actually increased the number of patients with insurance, but that didn't help if you couldn't find anybody to take your insurance. So we essentially reached the point where community need had exceeded our capacity to accept any new patients. So it was really kind of gut wrenching for me as a physician and my partners at the time to turn people away. We just at that time we had we were losing some providers to retirement and relocation, and some to illness, and so we had a shrinking number of providers and just more patients than we could take care of, and we could not take on any more. So we really just came to the conclusion that this model was not serving us well or the community well. So we realized that we had to do something different. What we've been doing for so long was no longer the right path. So we looked at options, and we decided at that time to transform ourselves from a private practice into a community health center. This is accomplished through what we learned was a very arduous process. It was a little more challenging than we initially had thought. It's a process where you have to apply for what's called a Section 330 grant, New Access Point grant through the Health Resources and Service Administration, or HRSA. These grants are made available periodically from the federal government to establish community health centers in areas that are medically underserved. And Port Angeles at that time in 2015 had this designation, this federal designation, as a medically underserved population, or a health professional shortage area, HPSA shortage area. That allowed us to be eligible to apply for this this Section 330 New Access Point grant. We had to, in order to apply for these grants, we had to demonstrate that we could successfully fulfill all of the obligations and requirements of a community health center and meet all the eligibility requirements. And it was about a year-long process to generate this grant application, and we were successful. It's a highly competitive process. There were about 2,000 applicants for the 164 awards that were available nationally. We were one of those 164 health centers successful at that time. And we were one of 2 in Washington State at the time. So that in typical federal fashion, we got the notice on May 1st of 2015, and they gave us 120 days to become fully operational as a community health center. So that's something like converting our Cessna into a 747 mid-flight in the 120 days. But we sunsetted the old practice and opened up September 1st, 2015 as North Olympic Healthcare Network. The reason we did this was we really thought it would accomplish a bunch of goals that we couldn't achieve otherwise. And primarily, we thought this model would help us address the immediate and long-term patient access needs that we were struggling with in the community for, up to that point. I'll talk a little more detail about this later, but the health center model also is more financially sustainable through what's called cost-based reimbursement. I'll talk about that a little bit later. There are some recruitment incentives through the National Health Service Corps Loan Repayment Program, which helps to attract providers to rural areas that have community health centers. This was the most important one for me, was that the community health center model really supported a broader scope of services for our patients that we could provide as a primary care practice alone. And we thought this model would also support medical education better. At the time, we were planning on starting a residency to train family physicians, but in our private practice model, it just wasn't going to be feasible. But under CHC model, it was much more feasible. So what exactly is a CHC or community health center? So you'll hear the terms federally qualified health center, or FQHC, and community health center, a CHC. Those are synonymous terms. They mean the same thing. They're referring to the same entity. The FQHC is typically used in the context of reimbursement eligibility, and the community health center is the clinical model, and that's my preferred reference. The health center program actually began in 1964. It was an extension of the civil rights movement at the time. It was based upon the premise that healthcare was a basic human right. And back in '64, as we find still exists today, there were large sections of the population which did not have access to basic healthcare. Those happened to be particularly underserved areas in inner city, urban, or rural areas were quite hit by shortages of healthcare professionals. So the health center program was signed into legislation by President Johnson in '64 to try and address this issue. And it's a program that has had historically very consistent bipartisan support. There's been expansion under virtually every administration. It had a pretty big expansion in the 1980s under the first President Bush, under his 1,000 points of light approach to addressing social needs. The next really big expansion happened in 2010 with the Affordable Care Act, and that was the ACA had among its various provisions included funding to expand the health center program. It was actually that pot of funds which made the New Access Point grant that we applied for in 2014 made that available. Under the Trump administration, there was a small expansion. I think they were a little surprised at how complicated healthcare was, and so they were kind of focused on other issues. Under the Biden administration, health centers have been just a real key to their pandemic response and recovery efforts, and you'll hear health centers elevated in some of the speeches and some of the press that comes from his administration. In all, there's about 1,400 community health centers nationwide that exist in all 50 states. It's actually collectively one of the biggest healthcare systems in the country. I think just ahead or slightly behind Kaiser. Collectively, they serve 30 million people. 8 million of those are kids, and 350,000 of them are veterans. The community health centers were the first integrated healthcare model. The concept of medical home was all the way back in '64. It proposed the idea that all of your facets of healthcare should be encompassed under one roof and one coordinated, integrated manner, including primary care, behavioral health, oral health, and OB and peds, nurse management, and including pharmacy and vision. There's a big emphasis on chronic care management and preventive care. This emphasis really helps to care management, preventive care, and coordination really makes health centers a really efficient, cost-efficient delivery model. Statistically, care given through a health center is about 24% less costly than any other system because of that integration and coordination. Health centers provide enabling services like transportation or translation that help. So if you have non-medical barriers to accessing care, health centers provide those services to break down those barriers to patient navigators. Many health centers are also teaching centers for healthcare education, residencies, or other healthcare professionals are often found inside health centers because it's a great learning environment. And health centers, by their nature, are collaborative beasts. Unlike a private practice, which is sort of takes care of business, focusing on what's going on inside its four walls primarily, health centers are sort of outwardly focused on making connections in the community and working collaboratively to help identify needs and helping to solve those needs. So there's some benefits to being a health center. Financially, there's you get what's called cost-based reimbursement for Medicaid. So any healthcare providers who may be on the call might know that typically for if it costs me $1 to provide service, Medicaid, patients with Medicaid as their medical insurance will reimburse about 33 cents. So it makes it really difficult to have a large proportion of your volume to be Medicaid and still remain solvent. So in many areas of the country, Medicaid patients with Medicaid will have difficulty accessing care because there's often limits to how much any practice will see. With health centers, there's basically an agreement between us and our federal funders. That is, in exchange for providing a comprehensive set of services that meet very extensive requirements I'll get into in a minute, and very high quality standards, and seeing all patients regardless of the ability to pay, whether they're insured or not. In exchange for that compact, then we're guaranteed to be paid what it costs us to provide those services. So we do what's called a cost report about what it costs. We're paid on that basis. So there's no disincentive to providing open access to patients with Medicaid. We have access to federal grants, special access because of our FQHC or CHC designation. We keep ours to about 12%. We don't want to have too much reliance on federal grants, but it gives us access to help start new programs, to get some things launched, and help expand the scope and range of services. We have access to loan repayment incentives to the National Service Corps. So health professionals finishing their postgraduate training can qualify for loan repayment by working at a community health center that's been designated by the National Service Corps as eligible. This actually is a big savings. Health centers have coverage for malpractice through what's called the Federal Tort Claims Act, or FTCA. And basically the federal government is our malpractice insurer, which saves us a lot of money for private malpractice coverage, and we can use those dollars to help direct towards patient services. We have access to some reduced cost of pharmaceutical purchases through what's called the 340B program, which I won't go into great detail with today. We're just a lot better better environment for training. Both the environment and the economics are better for training healthcare professionals. As I mentioned, really the biggest benefit is that we can expand the kinds of services that we provide for patients that I sort of outlined earlier. And that, really we're mission driven. We get to coalesce behind a particular mission, and that propels us forward. It gives us a lot of momentum and can accomplish a lot of good things behind a specific community-oriented mission. But it's not all unicorns and rainbows. There's a lot of requirements to go along with this. And a fundamental one is that we had to fundamentally restructure what we were. So we basically gave up ownership of the practice to become a 501c3 nonprofit that is governed by a patient board. By HRSA's requirements, at least 51% of our governing board must be composed of patients. Ours is, I think, 95%. The philosophy is that they want the patients to have control over the kinds and types of services that meet their needs as representatives of the community. So that was a fundamental change for us in that transition. It's been a very good one. Another key requirement is that we provide access to care regardless of ability to pay, whether you have insurance or not. We have a sliding fee scale program that adjusts fees based upon household size and income to reduce charges all the way down to zero, to no charge, depending upon your qualifications. We're required to have a very robust quality improvement program. We have to report our quality metrics annually to HRSA, and there are penalties if we do not actually achieve certain quality standards and keep QA processes in place. We dedicate, it wasn't a big lift for us because even as FMPA, we had a big focus on quality. So we have leveraged that forward under NOHN. We've achieved level 3 patient-centered medical home recognition by the National Committee for Quality Assurance as a patient-centered medical home. It's the highest level you can get as a recognition of quality of care and quality of your processes. We have a lot of reporting and accountability that we're subject to. We have to report clinical outcomes, service volumes, cost, utilization, staffing, all on a regular basis to HRSA. And we have a lot of rules, regulations that we are subject to. There's 320 separate regulations that we have to be in full compliance with it at all times, which takes a lot of administrative burden to kind of make sure we remain in compliance. We're subject to federal site visits every 3 years and must demonstrate 100% compliance with every bit of it. Otherwise, we can lose our designation. And we have to reapply for our status as an FQHC every 3 years through what's called a service area competition. So basically, we have to reapply for that grant every 3 years. But the impact on access has been worth it. Since we've become an FQHC, we've been successful in recruiting 11 new physicians to the community. And if you remember back, 2014, the whole reason we did this is because there was difficulty getting new doctors into town. So we brought in 11 new MDs and 6 new APCs. And we now have a total of 27 medical providers, which has been just had a huge impact on access. During this time, we've taken on 10,000 new patients. These are people who previously were knocking on doors and unable to find a primary care physician, and they now have medical home because of that increased access. We've gone from about 5,000 patients to over 15,000 over this time. About a third of our patients are Medicaid, a little more are Medicare, and 30% are commercial. A common misconception I kind of hear floating out there is that FQHCs are just where Medicaid patients go, and that's not actually true. In some communities that might be the case, but certainly not all, and certainly not ours. We see that, as our mission statement says, we are here for everyone, and that's regardless of the insurance, and we see the full swath. We are safety net providers for patients who do not have insurance. And again, as I mentioned, the sliding fee scale all the way down to no charges if qualified. We've been able to increase behavioral health staff and brought on 2 psychiatrists to help with medication management and counselors to help with counseling for common issues like depression and anxiety. As we all know, during this pandemic, there's been a huge increase in demand for those services. We have 18 medication-assisted treatment capable providers. So you may remember the hullabaloo out in Squim about the SOS people who were opposed to Jamestown's healing center. this is in Port Angeles. We've been providing this service to the community for the past 6 years. It's just integrated into what we do. It's not disruptive. We treat about 500 individual patients a year to help them successfully treat their opioid use disorder, and it's been a very effective program. We provided new dental access for adults with Medicaid. So historically, because of those low reimbursement rates, only about 23% of adults with Medicaid ever got access to dental care. And we opened up a dental clinic, a 7-chair dental clinic back in 2019 that got them access to dental care to give them treatment and prevention. Before that, they were all ending up in the ER with advanced dental decay and gum disease and pain. Since we opened this dental clinic, it's really had a big impact on getting patients that care and keeping them out of the ER. We've been able to expand our medical education offerings and help address the healthcare workforce pipeline. We started our residency with Swedish OMC. I'll do a little more detail on that later. We're a training site for medical students at the University of Washington through the Wright program. We're also a clinical training site for practicums for the Peninsula College Medical Assistant program and nursing students. And we have a lot of community collaborations. I'll go into a little more detail of that in a bit, but we seek out collaborations and work really effectively with other healthcare organizations. So some of those I just want to highlight is our collaboration with the school district. So since about, I think, 2018, we have been at the high school providing medical and behavioral health on a limited basis at a fixed site at the high school. What we learned is that really there was more need all throughout the district. In fact, the school district was starting to transport elementary and middle school kids up, particularly for behavioral health services, up to our clinic at the high school. And so we thought the best way to address this would be to go out to them, excuse me, through a mobile health clinic. And this just arrived last week. You may have seen it around town. It's kind of hard to miss, but it's our new mobile health clinic that is going to bring medical, behavioral, and dental care services to each of the school sites on a rotating basis, both elementary, middle, and high schools. And really is going to provide, in addition to this, we're reaching out to provide more behavioral services to students and parents at the schools themselves outside the mobile unit. And we were able to find some private grant funding that we were using to give to the school district to support expanding their school family navigators to help interface with connecting students with services both at NOHN and elsewhere in the community. We have a collaboration with PA Fire Department through the Community Paramedicine Program. This is something we provide some financial support for early on, but this private grant that we were successful in obtaining is also directing funds to expand the paramedicine program to fund another 2 full positions. The community paramedics do a really great job at doing proactive outreach to high-risk, high ER utilizing members of the community, trying to keep them out of the ER. In fact, they've reduced that population's utilization of the ER by almost 70%. It's been really very effective. They're providing immunizations in the field, including COVID-19. They interface with social services and our patient navigators here at NOHN to help address social determinants of health deficiencies. And they interface with the rediscovery program with through the police department. Also, they participate in the community case management team to kind of take a coordinated approach to making sure these patients are receiving all the services they need. So back in December 2019, I actually got a call from Jamestown and saying that they had access to some the new vaccine that was so hard to get, and they asked if we wanted some, and we said absolutely. And so we reached out to the health department at that time and said, is there some way that we could leverage this vaccine into mass vaccination clinics, an effort here in Port Angeles. Jamestown was doing a great job at setting something up in Sequim, and we want to do something in Port Angeles. So the health department and the EOC just did a fantastic job of doing all the logistics of getting this mass vaccination effort put together. We provided the staff, and Jamestown helped provide the vaccine and really helped us achieve some really high vaccination rates. We, in fact, among the state's highest in the beginning, did those efforts in Sequim and here in PA. And one thing is really, I'm not sure everyone in the community has full appreciation of, but there's a strong culture of cooperation and coordination amongst all the different healthcare entities in our county. So OMC, Jamestown, North Olympic, and Health Department, travel clinics out west, and Forks. We do a lot of regular meetings to coordinate a response to the pandemic and work on other projects together. I think we're really positioned well for, God forbid, the next pandemic or disaster hits. I think we already have a culture of working cooperatively to address those needs. We have a collaboration with Swedish and OMC around the World Training Track Residency for Family Medicine. We started this back in 2017, where the residents will spend their first year at Swedish, and they spend the next 2 years here in Port Angeles at North Olympic Healthcare Network to do their ambulatory care, outpatient experience, and OMC for their inpatient experience. We've graduated 2 cohorts. It was 2 residents per year, and 2 have actually graduated from the program, and 2 of them have stayed already. So already sort of meets statistical observations. About half of those that train in community will stay in that community, and that's what's happened here. So 2 of those physicians have actually stayed with NOHN. The program has been so successful, we expanded to 3 residents per year as of this past year. So there's now 3 residents in Seattle who will be joining us in June as starting 3 residents here. And then we're looking at other health professional training programs because this has been such a successful program, looking at clinical pharmacy, behavioral health training, and others. I want to talk a little bit about the economic impact. We've gone from 35 employees to 130 living wage jobs. We have an annual payroll of 10.5 million. That makes us an economic driver in the community. We bring a lot of dollars into the community through our efforts and through our staff. I think we're one of the larger downtown employers. We expanded our services to First Street, the expanded services building in 2018, and brought some increased behavioral health and same-day medical access at that site. That's also where our 7-chair dental clinic opened, as I said, in May of 2019. We opened our 3rd site doing administrative focus at the Administrative Services Center next door to the old Cowboy Country. Everything still smells like leather in there. I always feel like I should have spurs when I walk in there. Looking to the future, we are planning, as you may have read, we're planning to open a new service site next year at 1023 East First Street, the old Fanaticus or Edna's place, where we hope to close on that next month. We're going to be adding additional primary care access, adding vision services, and likely pharmacy, in addition to expanding our telehealth capacity at that site. We expect to have somewhere between 20 and 25 new living wage jobs, bringing us over 150 employees by the end of next year. And then we'll be looking at one of the things that we do every 3 years is community needs assessment, sort of assessing what services the community needs, what gaps are present, and what we can do to try and help fill those gaps. I want to spend the last couple of minutes just sort of addressing some of the challenges that we've been facing. Number one is, I think, with everyone on the call, who workforce has been one of the biggest challenges. It's always been a challenge, but during the pandemic, it's been especially difficult. especially for medical assistants and dental assistants. They are just few and far between, and this is not only local, but it's a state and national issue. A big challenge that's probably not unique to healthcare, but we certainly feel it in healthcare, and it's been a change, is finding we find that most medical providers are reducing their FTE. So we have lots of people, but because of work-life balance issues, they are reluctant to work full-time. So that makes it more difficult to have sufficient workforce to get patients all the care they need. So it's a constant balancing act between having enough time in the clinic and having time at home with their families. And this is a big one. I know, in fact, the earlier call I was on with the EDC here was talking about housing and the housing struggles. And we certainly have felt that at NOHN. We've lost a couple of employees simply because they couldn't afford to stay in the community. Their house was converted to an Airbnb, and they couldn't find affordable housing, and so they left the community for someplace else where they could afford to find someplace to live. I see this issue as being a big one for every industry, but for those of us in healthcare, it's having real effects. Another big challenge during the pandemic is maintaining workplace safety, both for our staff and for our patients. We had to basically reinvent the wheel back in early 2020 on how to redesign our workflows to keep patients and staff safe. And we were fortunate that we were successful in doing that. A big part of this is lately has been the COVID vaccine. We've achieved a 96% vaccination rate amongst our staff. Just a small handful that have received religious exemptions and are getting accommodations for that. The great majority of our staff are vaccinated. We've been able to date, knock on wood, have no infections in the facility, either among staff or between patients and staff. Financial sustainability, I think, is always a challenge for any organization, but particularly in healthcare. One of the big challenges is that wage inflation is a real thing, and in our reimbursement environment, we're reimbursed a fixed amount. So we, unlike other industries where you can increase the cost of your goods to cover your cost of your expenses, we can't really do that. And so that really makes it a challenge as we try to address wage inflation and do it sustainably. And then obviously we're at the mercy of state and federal healthcare financing policy. And there's, when you have changes in Olympia or changes in DC, those laws have very real impact on how we're reimbursed and what we're reimbursed for. And so it can be sometimes shifting sands is difficult to do planning with. But it's just the take-home message is that think of us as a community healthcare resource. We are a community health center. We're here for the community. We've been successful in improving access to care across that community and provide integrated, full spectrum, high quality clinical services that are accessible to everyone. We are a major employer and an important economic driver in the community. We're a safety net provider. As I said, we're here for everybody, regardless of insurance. We've been successful leveraging some important federal resources for community benefit. And I think we're positioned quite well to address the long-term healthcare workforce needs with our training program. That we are a mission-driven and collaborative community partner. And that's all I got. I talk fast. I hope I tend to mumble, so apologies if that happened. I'm happy to take any questions if there are any.
Okay, great. Thank you. I'm going to take it off of sharing screen. There we go. Okay. I saw some questions in the chat, but one thing I'd love to begin with is, can you share with us like the top 2 or 3 specialty needs that you see that we don't have in this community, that if you had, your way, you would automatically be able to,
Magic wand?
recruit a couple different experts in their fields? What is that you see a big need for, that we're constantly having to get folks to drive to Seattle or wherever to get those services?
Well, the top 3 are all behavioral health. I mean, counselors. I mean, I know you've read about it, heard about it, but it's a very real thing. There are nationwide shortages of behavioral health specialists, counselors, licensed mental health counselors, and psychiatry. Behavioral health has been, as a system, has been underfunded from the get-go, and we're reaping that crop now. There's just way too much need. So behavioral therapists are a big one. As far as medically, I think rheumatologists and endocrinologists are specialists that we, especially in our older population here in Clallam County, often there's a lot of joint-related disease that having rheumatologists around would be very helpful. There's a lot of diabetes. Primary care physicians do a really good job with managing diabetes, but there's definitely some need for diabetes and broader endocrinology. But those are very hard specialists to find, even in urban centers.
Okay. Debbie had a question. Debbie, do you want to ask that?
I was wondering if any assessments have been done in the outlying areas like Forks, and what kind of services you plan. Do you plan on using your mobile unit to provide services out in the Forks area?
That's a good question. We've had Forks so that our service area, it goes from all the way past Squim to Forks. So that's our service area where HRSA says that we can offer our services. And the West End has definitely been on our radar, but that only to the extent that we felt were needed. I've talked with Heidi Anderson at Forks Hospital, and we've had some initial discussions of trying to find ways, things that we can bring that they feel like they need. Our goal is not to go into a place and just sort of take over. It's really to say, is there a need in that community, and can we help to fill that ourselves or work collaboratively? Forks does a pretty good job. About 10 to 15% of our patients come from the West End, so they travel all the way into Port Angeles for their care. And so we've been considering for a while about putting a small clinic out there, or bringing dental services certainly out to the West End once we have the kind of the bandwidth and capacity to do so. So it's an active discussion. It's interesting you mentioned the mobile unit. That's one of the things we've thought about as a sort of initial step is when it's not in use at the schools, can we bring it to the West End and just sort of bring some services there? But that takes a lot of planning. As the mobile units just arrived last week.
And Lena has a question.
Thank you for all of the information. It's been interesting to learn about your organization. My question is, are you currently accepting new patients, or is there a wait list?
The answer is yes, we're always accepting new patients. In fact, we will never be closed. Our goal is part of our expansion is we're trying to get out in front of the curve, the need curve, so we always have enough providers to be able to take in new patients. There was, back when we first started, there was a wait list that was like 9 or 10 months long, and we got that whittled down to about 2 weeks. And as practices, as a new physician comes in, they have more capacity in their schedule. They'll take new patients in at a rapid rate, and it starts to fill up. And then their ability to take on new people, that rate goes down. So we're finding that things have been kind of pushed out now about 8 weeks or so for a new physician, and we want to get that back down. Our strategic goal is to have that under 30 days. But So yes, we are taking new patients. There is a bit of a wait list, but we're trying to prioritize people who don't currently have care, people who are new to the community or have not engaged with a physician. We're trying to prioritize those over people who are just looking to switch doctors, although we'll accept them as well.
So Steve Bierman has a question. Steve.
Yes, I'll just read it. Are you currently doing, or does it make sense to provide facilities for clinically based medical research, which would presumably bring in additional resources, monetary, equipment, and expertise?
Clinical research has not been a big part of what we've been looking at, Steve. It's we kind of toyed around with we had a grants manager who kind of brought some potential opportunities, but there's a lot of bandwidth required to do that well. And we just, it's not been a primary focus right now. There's some other issues I didn't go into, but it has to do with scope issues with HRSA about what things you're allowed to do as a health center. And I believe that clinical research is part of that, but it's not something which is high on our priority list right now, just because of the bandwidth required.
Mm-hmm. So Debbie asked, what are your requirements for the unvaccinated to receive care?
Whether you're vaccinated or unvaccinated, everyone wears a mask. I assume that's what her question is. So yeah, we still take care of patients who are unvaccinated. We'll try and encourage them to protect themselves and everyone else by getting vaccinated, because it's the most effective and safest way to prevent getting COVID. But there are no restrictions. We'll still see patients who are not vaccinated, but you will be required to remain masked at all times.
Mm-hmm. So I'm curious, over the last certainly 20 years, but maybe it's 10 or 15, Olympic Medical Center has grown exponentially. And I think a big driver of that was because the reimbursement rates for Medicare and Medicaid were higher if you were connected to a hospital. So and tell me if this is the story I think I understood, and perhaps I got it wrong, but that independent physicians clinics that were for profit just weren't able to manage all of the insurance requirements. It was very burdensome, and their reimbursement rates were better if they connected to a hospital. Is that correct? And then does that apply to NOHN as well?
That's yes, kind of. So I'm not the expert on the hospital's reimbursement system, but my understanding is what you're referring to is that they qualified because they were associated with a hospital. That any outpatient clinics that were associated with the hospital could qualify for getting what's called a facility-based reimbursement. So they got basically a bill from the doctor and also a bill from the facility. And so that collectively, that increased the amount of reimbursement that came to OMC when somebody saw an outpatient clinic. There was a change a few years back where CMS said for that to qualify, it has to be within 350 yards or feet or something from the hospital, which meant that all their other clinics were no longer able to qualify for that reimbursement. And so that created real budgetary stress for the hospitals. So that's why they've been sort of kind of retooling. For somebody who is not associated with the hospital, they don't qualify for those additional fees, additional reimbursement. So they're kind of at the mercy of whatever the payer mix that they have. I'm not sure if that becomes a driver specifically, but many, there just are not many private physicians, private practices out there. Certainly no new ones. There's some private practice solo docs who I think are going to retire in the next 5 or 10 years. I do not see anybody else coming in wanting to run a private practice, invest in one. And so I think that model really, particularly in our community, is just going to go away and this is a trend nationwide. For North Olympic, we don't get that facility fee. Our reimbursement is a little different. It's encounter based upon a cost report for Medicare and Medicaid, which helps provide relative to, if we weren't in FQHC, it's higher reimbursement, but it's not, it's a different structure than the hospital has.
Mhm, mhm. So I see Luke Robbins, president of Peninsula College, has commented in the chat, and I'd love to learn a little bit more about the workforce connectivity that you have in the county. So I was fascinated to hear you had a program with Peninsula or Port Angeles High School, and then with the college, and then you're doing residency. That's just amazing. And, you know, just think if every large business out there had those kind of connections. But what percentage of the employees that you in your growth have come from these educational programs? And is there something that, you know, you have in your plans to improve that process?
Yeah, Luke may want to comment from his end, but yeah, we would actually, I don't have the percentage, but for sure, but just sort of ticking off in my brain, I think the probably at least 70% of our medical assistants came through the MA program at the college. Part of their training is from the colleges, they'll spend some time in a clinic, and we get a chance to train them, and we would hire every single one of them. If of course OMC in Jamestown wants to hire them too, so there's often we don't get to keep them all, but we keep a high percentage of them, and they're all high quality. The college went and expanded the MA program. It's just that for other reasons, correct me if I'm wrong, Luke, they didn't fill that. There weren't enough people electing to enter that training path and that career pathway. There's a guaranteed job at the end of that. It's just that they were looking for other occupations. Is that right, Luke? Would you say that?
Yeah, it's yeah, medical assistants and a shortage of medical assistants is a national problem. It's not just local. Part of that is just the dynamic of the business model, frankly. Students, ask questions about why would I go through an 18-month program and make X amount when I can go into a nursing program and go for 2 years and make X plus, X squared. And so they make decisions about that. One of the other challenges is going through an MA curriculum is sort of a cul-de-sac, if you will. There aren't good transitional opportunities from MA to registered nurse, for instance, because of the way the curriculum and the accreditations and things like that work. And so that's one of the ongoing things we struggle with is, helping, people understand how attractive that position might be, and what sort of career opportunities there are beyond an entry-level position. That, continues to be a little bit of a challenge. But one of the things I would say about NOHN, and I'm a board member, so I'll say that up front. I sit on the board, but I'm also a patient. That's why I'm on the board. And I think, opportunities for MAs are particularly interesting at NOHN because of the way they approach patient care, which is as a team approach. And so the medical assistants at NOHN, Mike, I would say, are operating at the top of their scope of practice. In other words, they get to do stuff there that they might not get to do someplace else. And if they're really interested in serving patients, it's a great place for MAs to work.
I agree. That's a good summary.
So if someone does the 18 months of training to become a medical assistant, and then they decide, okay, actually, I think I want to progress and become a nurse, do they have to start over entirely with their training? Nothing, there's no articulation of some of the courses into nursing?
There's very little articulation, and let me hasten to add, that's not because we make it that way. It's because of the requirements for nursing entry into practice, which is determined by State Board of Nursing, National Board of Nursing, et cetera. And so there has been traditionally a pathway for students who went through what used to be called a practical nursing program to make a transition to an associate degree registered nursing program, but from medical assisting or other fields like that into an RN program. And ours is basically a 2-year associate degree RN program. It's a problematical transition.
So can I ask what the starting salary at NOHN is for a medical assistant?
Our CFO is on the is on the call.
Oh, I'm putting you on the spot there.
Yeah, thank you, Mike. The starting salary for an MA currently is about $22 per hour.
Okay. And then, so if they do that extra 6 months going to an associate's degree, what is that term called again? The nursing?
So our students are an associate degree RN. They sit for the RN exam, and they are, assuming they pass that, which our students always do, then they are an RN, but they've gone through an associate degree program. And then many of them finish up like a bridge program and either get a BSN, which would be a bachelor's degree, or they transition directly to an MSN, which is the master's degree equivalent. After they spend some time, usually in a clinical situation.
And so you have them do the clinical work at NOHN. Do they also do it, I assume, at OMC and Jamestown and Forks Community Hospital, right, and also like Lower Elwha Tribes
Exactly.
Clinic?
They do a whole series of clinical rotation, and they rotate through several different clinical sites so that they get different experiences. They get some experiences like in OBGYN and peds. They get some, critical care sorts of work. They get some, it's designed to give them a really broad introduction to the kind of work that a registered nurse would do. And, then I would say, this is a footnote, but, the vast majority of the students who graduate from our program, both in medical assisting and in the associate degree nursing program, stay in the area. The vast majority of them are still around in this general area, working at one of our medical providers.
So if you could snap your fingers and change the system so that it worked for our community, what would that be? Would it be paying medical assistants more and have the capacity to do that? Would it be the state laws would change for what the requirements are? What would that be?
I would, my opinion is, I think we could increase the people attracted to the MA program if there was that articulation to go on to another step. I think that would help part of the problem. But it's people, some may be hesitant to commit to this path and feel like, well, I don't have any other choice. I have to back out and go someplace else. Even if you had people stay for 4 or 5 years in an MA career on their way to something else, that would help. I think that does have to happen at the state board level. And obviously, increasing the wages of anybody ends up creating ripple effects. So basically, you increase it, it's that wage inflation all the way up. And what gets really hard is as I mentioned, in a reimbursement model where you're paid a fixed amount, as those wages go up, you can't increase your revenue to pay for those increases, which makes it really difficult unless you see a lot more patients, which requires a lot more stress on the providers doing that care, because they have to see more people in the same amount of time, which isn't good for care, which isn't good for them. So it's a recipe which is really a constant challenge, and trying to find that balance is really, really hard. But So yeah, there's if it's snap finger, if there was a way to increase reimbursement across the board, so that we would support wage escalations across the board, that'd be great.
Mhm, mhm. Well, terrific. And I see one last question from Debbie. Can people transfer from OMC? Do you
Sure.
mean that Debbie is a patient transferring or as an employee?
As a patient,
Okay.
because OMC, I mean, primary care doctors at OMC, I've had 4 changes in the last year. So it makes me, I'd like to get somebody that's a little bit more stable and that can answer the questions I have.
But in defense of OMC, they've experienced a lot of challenges as we have, just with provider turnover. It's hard to get providers to come to the community and stay in the community, and it's they do a really good job attracting good people, but there's sort of that they're not in control about who comes and who stays. But so they're trying really hard to meet those needs. But it can be frustrating for patients. And there's been some turnover here. I mean, I just gave up my practice of 30 years, and my patients aren't real happy that suddenly they have to see another doctor as well. So it's with every organization you'll find that, Debbie. But to answer your question, yes, we're open to all patients. As I said, we're strategically prioritizing those that don't have care right now if they're new to the community. But if you get on the list and say, okay, when there's an opening, maybe 8-10 weeks, then we can get you in. Sorry. Hope that answers your question.
Well, thank you so much for spending some time with us. I think we were saying in the chat, Hope was mentioning how incredible this organization is and what it provides to the community. And I certainly wasn't, I saw NOHN and I was like, what's that about? Not really, not understanding at all what a community health center was. And we just really appreciate all you're doing, especially the incredibly strong connection that you have with training and, as part of our economy, providing jobs and training from the high school to the college to internships. That's just remarkable. And I wish we had more examples of that. I think that's the ideal across our county. So thank you for all you do and congratulations on the great success you've had.
Thank you very much. It's been a pleasure, and we'll just keep doing the work and hopefully see some good things happen for the community.
Great. Thank you so much.
Yeah, take care. Thank you.